Welcome to COVID-19, the Orthopedic Response. We're a production of DOCSF, which is a conference that's based out of UCSF. I'm your host, Shauna Butler, and we're thrilled to be joined by the American Academy of Orthopedic Surgeons as a global convener to help us address this uncharted territory and unprecedented moment in time. And I'm really thrilled actually to have this global audience joining us to help us think about all of the different things that we're challenged with. And I'm thrilled today to bring to the audience Dr. Vonda Wright. She is an orthopedic surgeon, and let me see if I can get her up on our screen. Vonda, we have your slides with us. Can you? Yeah, we can hear you. Great. Um, so I'm going to introduce you just real quick, and we'll have your slides. And I'm sure that during this moment, we'll get you back on the screen so that we can see you visually. And if the audience is out there, if you can let me know if you guys can hear Vonda, that would be really helpful. So Vonda is an orthopedic surgeon, amongst other things, researcher, entrepreneur, at Northside Hospital in Atlanta, Georgia. And there she is the chief of sports medicine at the Orthopedic Institute. Vonda, you want to run through that title so that we make sure that we've got that right? Okay, great. And the audience is letting us know that they cannot hear you. Could I get you to take just a minute and try refresh your screen, and let's see if that helps. Perfect. Great. And if you can bring your slides up for us again.
Oh, yes. Here we go. All right. I'm trying to hover over myself, and it's not coming. Oh, here we go. Did you get them?
You are a ninja. So actually, before we dive into that, let's talk a little bit. No. Like I said, we are a community of learners, and we have a group of people out there who are a very generous audience who are cheering us on, wanting to see us succeed. And I think one of the things that's really great at this moment in time is that it allows us to bring our real selves, the challenges that we have. And if we ever needed a moment to be humbled, I feel like, every day learning new things. And I think it's really great to be transparent in the fact that we are learning and we're learning together. So thank you for your patience. And you have a remarkable story. So at Northside, let's talk about the size and the scale of the department and the practice that you run.
So, Northside Hospital is, according to the Atlanta Business Journal, the largest hospital system by revenue in the region. And so they started out as a as one hospital, a community hospital, and really have grown to a health system that spans the entire northern wedge of the city. And so until 2 years ago, they were host to 147 mostly private practice orthopedic surgeons. And then they decided very wisely that they needed to invest in their own orthopedic surgery department. So prior to my arrival 2 years ago, they had a total joint practice, which has become very robust. And over the last 2 years, we have added to that in the Orthopedic Institute the other subsections of orthopedics that everyone practices, with the exception of true pediatric orthopedics and the congenital type maladies that pediatric orthopedics takes care of. So for all intents and purposes, it's an academic department, although we're more close to a privatemic. You know, we still function as a privatemic, although we're owned by the hospital. So we're 2 years old. We have 25 doctors. 21 of those are surgeons. 4 are non-operative sports medicine doctors, 14 PAs, and in 16 locations, with 6 of those being hubs, meaning that in those locations, there are larger locations. They're co-located with radiology, physical therapy, everything an athlete and active person would need all in one place. So
that was 3 weeks ago, right? That was 3 weeks ago.
Well, that was 3 weeks ago, and I'll tell you what we're doing now. But
because what that looked like 3 weeks ago and what you've done in this incredibly short period of time is miraculous, Herculean. So I want you, I mean, that was why we reached out to you to talk about this literally pivot on a point and go from what you just described to what you are doing today. So let's talk about what you're doing today.
Well, and part of that, most of that, is having the right staff, both medical staff, clinical staff, and administrative staff, executing to pivot. So I just put up in this first slide that our COVID.
Let me go ahead and get your slides, enlarge them. So you go ahead and walk through. But I wanted to make sure that we set the stage for people to understand what you're going to walk us through here.
That's right. So basically, we have a large department and a wide geographic and number of offices. And so the first slide that I have up here is really our timeline, because I think the rapidity of how we made the changes is one of the very interesting parts of this. And I know everyone has done this, but so people who have not made this change yet, I thought it would be interesting for you to know everything we considered in getting this done. So March 10th, schools were closed in one of the main counties that we work in. And that night, March 11th, I did a deep dive into all the data and really coalescing and becoming a scholar of COVID, and really was convicted that we had to protect our patients and our staffs, that we still had to care for the urgent and acute musculoskeletal problems, but also conserve resources, because at that point, I did not know what our stockpiles of PPE were. So our staff is used to me texting day and night and knowing that it's just communication, not the expectation they're going to work in the middle of the night. But on March 12th, which was a Thursday, at 8 o'clock in the morning, because we had been texting earlier than that, we had the first administrative staff meeting, and the 3-phase program that I'm going to describe to you today was really brought from out of the back of my head, sifted through all of our administrative staff and off of a paper napkin, if you will, into a 3-pronged plan that was pretty detailed. Throughout the day Thursday and then Friday morning, we continued to develop that plan. But March 13th, we had a big kickoff, and I'm making a capital letter deal out of this, is because to build esprit de corps in frightening times like this, I believe that leadership has to pivot also from, usually departmental leaders will be strategic leaders. They will put together a plan and then ask it to be executed with the excellent people that you've hired to do the logistics in every day. But in a situation like this, in a war, if you will, I truly believe that those in charge need to show up. And so we made a big kickoff, which I think is important. By March 16th, so March 13th was a Friday. We worked all weekend. By March 16th, is our line in the sand. That's when we're starting to count our financial changes, our practice changes. That's a Monday. By Wednesday, we were live with Telemed, 25 physicians. And by March 23rd, phase 3, which I'm going to show you, was up. So that is pretty rapid because in many big systems, it takes time. So this is how we broke down the phases. Phase 1, we're going to make a plan to protect our patients and our staff, establish the COVID operational workflow, which I'm going to show you phase 1 in detail, and evaluate resource utilization and plan oversight. 2 very, very important parts of building a plan like this. Phase 2 is outlined there. It started on the first Monday, the 16th. Staff and MD education, telemedicine making it operational. And then we had to gather data because this is a dynamic changing plan every day. And then finally, phase 3, which we launched into on the 23rd, was consolidation and long-term resource management. So if we look at phase 1, like how do you actually do this, get it off the ground? These were all happening simultaneously. We had to minimize face-to-face patient interaction. So Friday and Monday, and even over the weekend, we called all the patients that were coming in the next 2 weeks on our schedule. It was all hands on deck. Everybody was calling our patients and asked them to voluntarily reschedule for 2 weeks in advance because we didn't know at that point how long this was going to be going on and whether Governor Kemp was actually going to shut down the state, which he actually did yesterday. So we asked them to reschedule 2 weeks ahead. 41% of our patients voluntarily rescheduled for 2 weeks. So that meant that we only then had to ask our physicians to review their clinic lists for the remaining 60% and to determine which of the patients were appropriate for telemedicine and which really, really, really still needed a face-to-face. So that was happening. At the same time, we were developing our pre-screening and clinical distancing plan. So we have a 3-part pre-screening procedure we go through, both the day before or at the time of appointment, the day before, and upon arrival, where they're not only given questions, but their temperatures are taken. We've also developed a clinical distancing plan for our staff. Normally in our offices, we may have 3 or 4 people sitting out at the front desk, but because volumes are lower, we took everybody away from the public that could and put them in back offices or phones that were distanced. At the same time, we were inventorying our PPE, and we found that we had used a lot of our supply and had not yet gotten the next normally scheduled set of PPE. So we had to plan according to how low our baseline supplies for, and then ask for staff availability because our schools have been closed and we employ a lot of parents. So counting those as resources. At the same time, these are all going on simultaneously. We were making a telemedicine action plan. Fortunately, we had already engaged a platform, which I'll tell you about. I appointed a champion. It was my own athletic trainer because she is our lead athletic trainer. What a champion means is she must know the platform better than anybody and serve as a resource for everybody. And then we scheduled trainings, which I'll get to. And then I think the last 2 points, oversight and the kickoff, are really, really important not to forget. In a strategic plan, sometimes you say things like point A must be executed, point B must be executed. For instance, here we'd said every surface must be wiped down every 10 minutes. We didn't stop with that. Every single office appointed a safety chairman who then put names to times and 2 locations, because remember, every detail matters. So this is how detailed these kinds of plans must be. So I know that Carrie is wiping down these surfaces with this material every time point, and everybody knows their job. It sounds very military, and actually it is very military. Everybody has their job and they know when to do it, and they're personally accountable.
Yeah.
Then I appointed or asked for volunteers actually for an MD task force. Even though I did a deep dive on November 11th, do not pretend to be a COVID expert. And so I asked my physicians, not only so that we would have more brains looking at this, but more buy-in. And we arranged an MD task force call every day at 4 p.m. because this was so fluid. And finally, multiple daily calls happened. And then we scheduled the big kickoff for Monday at 1 p.m. for everybody. So this is all happening simultaneously to set up for a big pivot. And then the big pivot happened on March 16th was the day, the line in the sand. So our telemedicine champion, our super user, had first a mandatory extender training in the morning. So if you're going to roll out something like this, I suggest that you train the extenders first. Then we had wave 1 mandatory physician training. It was a few hours. And then wave 2 and 3 the following day, so that by the 18th, which was Wednesday of the week, 25 doctors, all the sports medicine doctors and all of the total joint doctors were trained in telemedicine. And began seeing patients actually then on Thursday. The COVID plan that I just outlined for you was rolled out this whole week. And we decided that we not only needed this plan, but we needed to reconvene every day. So in every site, every day, we had a morning safety huddle. How's everybody doing? Taking their temperatures? What are the concerns from the day before? Because Shauna, as you like to say, execution is everything. If we're not checking on the execution, we're not going to get it done. And then finally, we had the PM task force calls, and adjustments were made every single day. And we got through the first week. And so here's just a little bit more tidbits on telemedicine. This is one of my doctors doing it from home. We are using the Amwell platform. It is a Cerner and Epic library platform that we had started to evaluate, because when we started, you actually needed a platform. And then Trump and CMS relaxed some of the HIPAA and rules surrounding telemedicine. And now you can use anything, Zoom, FaceTime, Skype. And here are some of the billing codes. I know some of the audience is international, but in the United States, these are some of the codes that our revenue integrity have enabled us to use. And our billing is largely by time spent and complexity. A few lessons that we learned is not a surprise to anyone that works with us day to day, is physicians are impatient and it takes a little bit. And we had to, and changing habits is not that easy. And we had to do multiple tutorials. The first time our docs got on, our champion was on the phone with them. But the fact that we started out with a big kickoff and had a task force involved is we have such a esprit de corps. Everybody's working together. And I would really encourage people rolling out a big plan like that to do that also. So before
before you go into that, that point that you brought up about being impatient. In this, have you been able to identify the source of the impatience? I mean, what is creating the impatience? Is it, I want to be able to learn this fast enough? I feel like I'm not. I mean, have you got any insight into what are people impatient about? What's creating the impatience?
Well, I think it is truthful to say that whether we're in the operating room or whether we're in our clinics, having a routine and a workflow that one goes after each other, there's an efficiency in sameness. So the fact that this was a completely different workflow, here, I'll give you an example. So when I am seeing a live patient, I will do all my work because I refuse to chart in front of people. It's not personal enough for me, the way I see patients. I'll come out of the room and I'll dictate. When I'm on telemedicine, it enables me to have my iScribes person listening to the visit and write my note at the same time as I'm interacting with my patient, which is a new workflow for me. So surgeons get impatient when the workflow varies. Something's not there because efficiency matters to our patients, right? So there's an impatience of not understanding the system. Thus, our super user had to get on with each and every person when she was requested. There was an impatience as, this is not what I usually do. But I don't want to overplay. There was impatience, but there was tremendous esprit de corps. And literally everybody was proficient within the first week. But just for people recognizing it's going to happen. You're going to need to
that's
tutor
what
people.
I was just thinking is that, the way to diffuse or to mitigate impatience is to say, this is going to be disruptive. This is going to be learning.
That's right.
We all need to just recognize our efficiency is not going to be what it was. So we just take a deep breath and be patient with each other.
That's right.
That we're all learning together. So that was why I was asking, because that is some of the comments that I've been hearing is that tempers are short and there's a lot of impatience, and they're learning something that's new, and they're used to looking very competent at what they're doing.
Sure. And I'm a surgeon too, so I get that. But I have encouraged my staff, and both on our mandatory surgeon calls, which we do, and our staff calls, that we have to remember what we're doing. We're protecting our patients. We're protecting ourselves. We're being good stewards of resources. These are unprecedented times. Let's just refocus so we don't turn inward and be me, which is what sometimes we do in the OR, right? So what are we doing? What is our why?
How do we act collectively, behave and act collectively?
That's right. It's not mine right now. It is, everything's going to be okay together. And I don't mean to sound sappy, but that's the language I use. It's not only reassuring, but redirecting.
I'm going to give you permission. Lay it out there hard and heavy on the sappiness. We're going from me to we in this. So anyway, proceed, keep going. I didn't want to lose that point.
Got through the first week, right? We got through the first week. Everybody's talking. We have completely in 1 week changed our entire way we see patients. And then week 2 gets here, starting March 23rd, and we have not gotten our supply of PPE yet, but I have come to believe that all of our staff at all times must use masks. So how do we do that? So we're evaluating that as an input. How are we managing our staff? Who is calling off? Who has to be gone because of their children are out of school? Do we have someone sick? And then finally, we had to start, and everybody will have to start shifting roles. Just because you are a patient check-in person, during this time, you may be solely on the phones and reassigning those roles. But because we recognized that we did not have enough PPE to run 16 offices and all staff seeing patients, we started to make a plan in the beginning of week 2 to consolidate to our hub practices and ask, because of the decrease in volume, all of our clinicians to see their live patients, their remaining live patients, in 1 day. Now, we have some pretty high volume doctors who needed 2 days to do that. But the point being, we're going to concentrate the live visits and minimize staff exposure and use of PPE. So we gave that power back to the doctors. I said, doctors, choose the day and choose the clinic, because most of our doctors go to 2 places. And they did that. And then using that data, then our clinical manager made a grid so that our hub offices were open 5 days a week, because we get a lot of walk-in patients, and we had made a relationship with our urgent cares that we would do the musculoskeletal urgent care. All they needed to do was send people over. So hub consolidation to consolidate PPE use and staff exposure. Every physician, if their volume, unless their volume mandated 2 days, saw their live patients in 1 day. And then they could do telemedicine all the rest of the days they wanted to. And this week, we not only made a plan for this, implemented it on Thursday of this week, of this March 23rd week, and then started working on our long-term plan.
That's an awful lot to get done in a short period of time. And it's so funny that how the time frame shifts. We're talking about short term being on a day and long term thinking in terms of a week.
Well, and even since I made these slides 2 days ago for this, we have now progressed. We've decided this phase 3 was a great plan. It's going to serve us probably the whole month of April. But now we're shifting to phase 4, which is we need an actual plan for. Right now, our hospital has been completely flexible and generous in allowing us to keep all of our staff. And when the hospital has a need, we flex our people out to screen at the door of the hospital, for instance, or to fulfill the need of our hospital. But we need to have a plan in place just in case those circumstances changes. We also need to not ignore the fact that at some point we're going to get back to normal. And how do we do that? Because our surgeons have piles of surgeries to get rescheduled. And so I'm beginning to think about phase 4 now to address both of those issues. And next week, we'll start talking to our clinicians and our staff about phase 4. So this is a time to be nimble, to put egos aside.
So the phases stay the same. It's the time frame that adjusts.
Well, we're in phase 3 right now.
Right. So you've got each one of those phases, but when the phase gets activated, that timetable is what needs to be nimble. But the phase itself, what you're going to be doing, seems to be a little bit more stable.
Yes, I think the progression of how we did it is highly functional. To go from normal clinic to COVID clinic. I mean, I think the phases we rolled out are really logical and rational. When you do it, depends on individual circumstances, the day-to-day changes. And so
that anybody could take these phases and match it over to whatever time frame they are, wherever they are when these phases need to be activated.
That's right.
So you've created a roadmap.
That has worked for us, and it could be a guidance for other people who have not yet have to make these significant changes we have. So, but that's the last slide I had. So I don't know if you had questions or.
Yeah, let me go ahead and bring us back up on the screen. Yeah, actually there are. So very specific question. This is coming from Catherine, and she wants to know if you're using the standard outpatient E&M via telehealth with audio and video. So the 992, are you required to use time to code, or can you use the standard complexity requirements to code, which may take you less time?
Well, the hard part. Oh, go ahead.
And if you use the time, is a pre-visit prep, the imaging, the chart review, M&A to talk to the patient, is that allowable as part of the time documentation?
So the hard part about using standard E&M codes is that we're really not able to do a physical here. And some of those codes require detailed physical exam. So the way our revenue integrity had helped us get through that is to do it with time, because otherwise, I mean, I can't make up a physical. I frequently do have people show me their knees, but all I can tell from a knee is what I observe, which is range of motion. Is it red? Is it swollen? But I can't put hands on it. And so that's why time works for us. Interesting question about time for pre-prep. I do look at MRIs before I get online so that I know I like to have a game plan in my head, but I walk it through with the patient in real time. So, so those visits, if I spend 30 minutes with the patient, I will have gone through the MRI with them. I will have gone through all their questions with them. So I'm accounting for that. I'm not just accounting for the 10 minutes when I say, you got a meniscal tear, and when we come back, I'll fix that for you.
Okay. So Gregor has a question here. He wants to know, so he says that orthopedics in our institution have been calling patients for the last 2 weeks. The patients were universally very happy that we called, and it seemed that they presented with less disability, less complaints, less concerns. So when approached by the phone compared to a live visit, and he's wondering, have you had a similar experience?
They're less hurt when you call them on the phone?
Yeah.
Is that what he's saying?
It just sounds like that there are fewer complaints. It sounds like when you're preemptive about that and just giving somebody a call to check in,
Yeah.
and he was curious if you've had a similar experience.
We're doing two kinds of calls. So that's interesting you said that, Gregor. In phase 4 that we're starting now, we are going to just check in. Even if patients didn't have an appointment, we're touching base with them as you would with a friend to say, just checking in with you. We want you to know that we're still open. You don't have to go to the ER. And so we're going through the thousands of people in our database. We don't expect them to be hurt. On these telemedicine visits, they tend to be more streamlined than in the office. In the office, we go on, and at least this is my style. But on telemedicine, it's such a new platform. I find that maybe this is what you're saying, that they're really to the point. They just need their information. They're sitting on their couch or in bed, and it doesn't continue on and on. So I don't know if they're less hurt, if it's such a new environment, they don't feel comfortable yet.
And Wayne Johnson wanted to know, what percentage of your patient volume diminution have you experienced transitioning to telemedicine as opposed to your pre-COVID clinic visits?
So our that's a good question. The first time we asked people to voluntarily reschedule, 41% did it right off the bat. And then of the remaining 60%, we are seeing, the first week we did telemedicine, we were seeing about 30% of them telemedicine and still had a lot of people coming in. Now it's flipped. We're seeing about 30% live, just because we have to. There's some real there's some actual fracture and post-op happening, and new injuries. And then 60% is telemedicine. I suspect as we continue to progress, we're going to be nearly 90% telemedicine. So,
one of the questions in here, and I think that this is a nice segue into it, given all these changes that you're seeing, long-term plans. So, you said that you're grabbing a bunch of data, using that and incorporating that into your current plan. So is what you're seeing, let me ask you this way, based on what you're seeing right now,
yes.
How does that factor in, and what are you thinking that your long-term plan is going to look like?
For getting back to business as usual?
Yeah, well, I was going to say, it's business as usual. I think that's.
I don't think we're going back to the old way.
Yeah, I don't think it's. We talked about this earlier, and we say return to normal. I think it's when we return to an optimal. But as we move through the high rates of transmission, and we feel like we've got the communicable nature of this at a place where it's safer for us to be interacting in person. When we get a vaccine. Long-term plans for orthopedic care, what are you seeing that's going to look like?
So this is what I think is going to happen. I think out of this experience with changing what people perceive as urgent, meaning there are some patients where, and believe me, we are happy to see them, but that come in when their knee has hurt them for 2 days, versus the opposite side of the spectrum when people wait 6 months and we wish they would have come in 2 days. I think people having been forced to wait in the future, they may continue to think, well, it's only been 2 days. So I think we're going to see less of that, number one. Number two, our clinic, and this is part of our phase 4, will no longer just say, sure, come in. We'll say, would you prefer a telemedicine visit, or would you prefer to come in? Or would you prefer a phone call? Because now that we're becoming very effective at managing our phone time, and I've never billed my patients for my phone calls, but this is a new paradigm. Maybe we will adopt that in the future. Our patients will have multiple ways to engage with us. And I was just thinking about this today. I may, and check in with me next week when I've got phase 4 really going, but I anticipate needing to staff my offices differently, because when my doctors are really, really good at telemedicine, they're not going to need their staff sitting there to help them. And I may be able to shut down whole clinics because it's a telemedicine day. If it's not a hub where we're open 5 days a week, you can still be completely in business in a closed office. You know what I mean? I think it's going to really change the need for every office to be open 5 days a week, all those long hours. We'll still be able to see more patients with less staff, probably.
Imagine what that's going to do to the traffic in Atlanta. I like that one.
Well, there you go.
Well, when you were just mentioning that about a reduced amount of time, that also means reduced amount of face time within our teams, within our staff.
Mm-hmm.
So given that you guys are geographically distributed,
Mm-hmm.
working remotely and virtually, how are you coordinating? What's your communication method for teams?
So in week 1, we had 3 mandatory all-in phone calls. On all 137 staff were on the same call, listening to the same messaging. We're going to have a couple big calls on Monday for phase 4. And we just think more is less. We don't want people to be afraid. We don't want rumors to fly. I think over-communicating is the best way to do that, and having leadership at all levels at the table, not the coordinators that they're used to hearing it from, but the levels above them. At this time, it's very important. So we do those mandatory calls. If other leaders out there find that their physicians may or may not read the emails you send them, I have established a text stream, and on that goes all the COVID information that I'm gathering. They've started contributing. They read this text because they respond. So it's enabled us to communicate maybe even better than we ever have. And I was thinking of actually downloading the app House Party that my teenagers use, where 25 people can have their faces on a screen. And I mean, that might be fun next week. We'll see if we do that.
Yeah. Well, this has been great. Thank you so much for taking the time to share with us the very detailed plan and the phases and the timeline and how you've responded, the data that you've been looking at. You've been very generous in going through. I think that this is an interesting moment where we haven't normally shared these type of operational details to really bring. I mean, at what point in time have we, as a planet, been facing the exact same problem at the exact same time? So it gives us an opportunity to work together in ways that we haven't done before. And you are a very generous contributor to that. I know that you are widely available through all the social channels, and I encourage people to reach out to you. And again, thank you for spending the time with us today on COVID-19, the orthopedic response. Grateful to DOCSF and the team at UCSF and our partners at the American Academy of Orthopedic Surgeons. And I will see you online. Be well, stay home, stay connected, and see you next time.